Good morning. Your warm welcome to my topic, a short path to reach the destination. Let me introduce with the basic questions. What is condylar fracture, when it will get fractured and how it will get fractured. Condyle is one of the processes of a mandible. A complete or a partial break in a condylar process is called a condylar fracture. It has got many etiological factors like intentional trauma, unintentional trauma, direct impact, indirect impact, etc. A condyle may get displaced, dislocated, deviated or comminuted. One among the more classifications involves Rowe's and Killy's classification. They classifies into intracapsular and extracapsular. Our subcondylar fracture comes under extracapsular. A fracture line runs from the lowest point of curvature of the sigmoid notch obliquely downwards and backwards to the posterior aspect of the upper part of the ramus of a mandible. Now, the management part comes under two. Closed reduction and the open reduction. This will vary depending on the age of the patient and the type of the fracture. The obvious advantage of the closed reduction involves avoidance of the morbidity and the complications associated with the open reduction. But many a times it has got many disadvantages like internal derangement, inaccurate reduction, etc. So, the open reduction is performed because of anatomic reduction, stable fixation and the immediate results. There are indications when to open. According to Side and Kent criteria, there are two indications like absolute indications and relative indication. When there is a displacement into a middle cranial fossa, when there is an impossibility of obtaining adequate occlusion by closed reduction, when there is a lateral displacement, when there is an invasion by the foreign body, when there is a periodontal problems, when there is a loss of teeth, when there is a unilateral condylar fracture with unstable base, when there is a bilateral condylar fractures in edentulous patients without a splint, when there is a unilateral or bilateral condylar fractures where splinting cannot be accomplished for medical reasons or because physiotherapy is impossible, and when there is a bilateral condylar fractures with comminuted midfacial fractures, prognathism or retroprognathism. Let us get into the topic, that is we are mainly concerned about the open reduction, that is the management of a subcondylar fracture through the transparotid. Our destination is to reach the subcondylar fracture through the short path called transparotid. And why a transparotid? Because of its direct visualization, accurate reduction and osteosynthesis, precise wound closure, shorter working distance. That is why it is called a short path. Let me show in a schematic diagram. A retromandibular skin incision is done, dissection is done, a parotid gland is blunt dissected, a fracture site is exposed, the fracture fragment is repositioned, a mini-plate fixation is done and the suturing is done. I am elaborating with the case history. That is, a 25 years female patient reported to the Department of Oral Surgery with a pain on the left side of the earlobe for the past 2 weeks due to the personal assault. This is her first dental visit. On extraoral examination, there is a visible swelling in the left TMG region with a tenderness on palpation. On intraoral examination, there are no occlusal deformity. On investigations through the ZBCT of 3D reconstructions and OPG reveals the lateral displacement of a left subcondylar region which is unilateral. We should know the basics before going into the surgical technique. Retromandibular incision. It is a skin incision 3 to 4 cm parallel to the posterior border of the ramus of the mandible, commencing 0.5 cm below the earlobe. It was discovered by Hinz and Girotti. The presence of facial nerve in relation to the fracture site is very important. The bifurcation of the facial nerve is 12 to 20 mm inferior to the tragus, a frontal branch is 16 to 29 mm anterior to the tragus, the anterior branch of the facial nerve to the lateral pole of the condyle is 3 to 14 mm, temporal branch is 8 to 35 mm from the anterior concavity of the external aquastic meatus. The surgery was done. This surgery was done under the nasotracheal intubation. First, the incision planning is done, that is marking the outline of the posterior border of the mandible and outline of the retromandibular incision. Remember, this surgery is done under general anesthesia. And number 15, scalpel blade is taken for the incision. And the layer-wise dissection is done. Skin, superficial musculopeneurotic system, etc. While dissecting, a parotid capsule is identified, that is which is white glistening layer, and it is been dissected, and the gland is blunt dissected in a window between the buccal and the marginal mandibular branch. That is, we are preserving the facial nerve very carefully. With curved hemostat, the mesentery was exposed and the ankle of a mandible is exposed and the fracture site was exposed. Now, the fracture site was identified and now the repositioning of the fracture is done, that is the subcondylar fragment is repositioned to the glenoid fossa and distal fragment called ramus is repositioned to the subcondylar fracture and the mini plate fixation is done. Which mini plate fixation? That is 2 mm titanium implants, 4 holes with a bridge and 4 screws, 2 mm into 4 mm. Okay. Next comes the closure. The parietal capsule and the pterygomesenteric sling was sutured in 2 layers with 4-0 polygalactic acid sutures. Remember, this is a resorbable. And the skin was sutured using the 5-0 nylon suture, which is non-resorbable. Now, the discussion part comes. Many approaches have been proved useful for the condylar fractures under the open reduction. Okay? But the controversies regarding the efficient management gains significant clinical importance. There are many incisions like submandibular incision, preauricular incision, etc. other than the retromandibular incision. In a submandibular incision, it is large incision with a limited access, so it will be unaesthetic and it is very a hectic procedure because it will have a large area, it will have a large distance to reach our destination. In a preauricular incision, it is a cumbersome fixation with a limited ramal exposure. Okay. So, now the retromandibular incision is widely used and effective due to the direct access, less operative period and the aesthetic results. So, I recommend a retromandibular incision with transparotid approach proved to be effective in maintaining the profile and the closal harmony. Because with this approach, an adequate reduction is possible along with the immediate results. I will show you post-operative results, which is beautiful and aesthetics, and also a satisfactory functional outcome has come with a low morbidity and the patient satisfaction. Of course, there are complications like facial nerve injury and Fray syndrome, a silosyl, if we are accidentally injure a parotid gland or a nerve. So, that will be potentially avoided by the efficient operative skill and the experience. So, I conclude by saying there will be a better action when there is an initial visualization or a wide visualization. So, I recommend a transmandibular transparotid approach. Retromandibular transparotid approach is an effective and a safe technique with a better access for subcondylar fracture, and the good visibility and the efficient operative skill aids in the successful clinical outcome. Thank you.